Hello, everyone. Welcome. My name is Mariah Wiggins, and I am one of the research coordinators here with the CARE team at BMC. Thank you so much for coming here today. I want to welcome you to the PRONTO Best Practice Guidance for Post-Overdose Outreach. We're going to focus on public safety and public health partnerships. Our speakers for today, as you can see here, we have Dr. Alex Wally, Dr. Tracy C. Green. We're going to have Mary Wheeler and Brandon Del Pozo come on a little bit later, and all of them will introduce themselves when they get to that point. And this is today's agenda. So right now we're starting with the introduction, and then we'll soon get into the presentation given by Dr. Alex Wally and Dr. Tracy Green. Then we'll be followed up with a post-presentation panel discussion with Mary Wheeler and Brandon Del Pozo. Then at 12:50, we'll have a live Q&A session, but please note that during the whole session, you can submit questions to the Q&A feature. If you have an actual question, please submit it to the Q&A feature so we don't miss it. And you can also chat to our team using the chat feature throughout the entire session. If you have any questions or having any technology issues, please just send it in the chat. And then if you are able to stay on from 1 to 1:30, we will be having breakout room discussions. And I will get into a little more instructions with the breakout rooms when we get to that later on. Thank you again for being here. And now I'm going to pass it over to Alex.
Thank you so much, Mariah, and thanks for all the work you've put in to organize this today. We have over 200 people that are tuned in, and so we're really grateful for your time and the opportunity to take on what we think is a really important topic. So we're going to focus on the PRONTO post-overdose guidance. I'm going to lay out some background and really make the case for why we're doing this, and then Tracy's going to walk us through some of the highlights, and then we're going to get to hear from Mary and Brandon, who are both experts, and give their thoughts. And then we hope you'll stay around for the end. So I really want to thank everyone who's been involved with putting this together and the work over several years now. The starting point is Massachusetts. That's where I am now. It's where we really were inspired to do this work. In Massachusetts, like almost every other state in the country, we're facing higher opioid overdose deaths than have been seen before. Each state has its kind of own curve that tells its own story. In Massachusetts, we started to see fentanyl-driven overdose deaths in 2013, and then have had very high levels, over 2,000 people per year in the state who've died from opioid overdose deaths. And so this is something we've been facing for a while. Many public health and medical and public policy efforts have been implemented over this time, including an expansion of medication for opioid use disorder, as well as distributing naloxone as widely, and still it's not enough. And sorry, I need to jump back a couple slides. Jumped ahead on me. Okay, so August 31st, 2022 was the last International Overdose Awareness Day. And in Massachusetts, we commemorated it, well, in many different ways, but one way was by putting over 20,000 flags, which represented each individual who died from an opioid overdose related death in the last 10 years. So I started out with numbers, but I want to make sure that we all reflect and acknowledge that there are individual people who've lost their lives behind each one of these numbers. And so that's what really propels all of us on to continue to address the needless loss of life. And that's why this is important. overdose death is not distributed evenly in our communities, and particularly during the pandemic in the last couple of years. Certain populations have borne a higher proportion of the increases in overdose deaths than others. And in Massachusetts, that's Black, Hispanic, and Native populations, or American Indians. And so while we've had a largely flat overdose death rate across the whole population in Massachusetts for the last several years, the increases that we have seen have really been driven by some of our minoritized populations who've historically been excluded from healthcare and public health interventions. And so that's a focus that we need to really think about as we think about how to address overdose. And that's something that's been seen nationally. So here's a recent study that looked at overdose death rates across the United States and showed that there were particularly high rates in American Indian, Alaskan Natives, and Black populations, across the U.S. So in this context, what's the rationale for post-overdose outreach? I mentioned that we have some evidence-based public health and medical interventions that we know work, like medication for opioid use disorder and naloxone. But together, the way we're implementing them currently, it's not enough. And so one thing is to really look at the people that are highest risk. And in the case of opioid-related overdose deaths, individuals who survive an overdose, so overdose survivors, are at elevated risk for a recurrent overdose, and that recurrent overdose could be fatal. And so for this reason, focusing on overdose survivors is important. The opportunity to engage overdose survivors and their social networks occurs in the days following a non-fatal overdose, where you can connect them and offer evidence-based interventions like naloxone and other harm reduction approaches, medication for opioid use disorder, and then service linkage. There's a need and a gap that clearly exists. So some people refuse transport to an emergency department. So, and also the emergency department is not always the best venue for prevention. Furthermore, there's systemic stigmatization, as I mentioned, particularly among minoritized populations, that really can challenge engagement. So the post-overdose program, to really engage these high-risk populations, needs to think about how best to work with them. As far as the intervention itself, the post-overdose outreach follows up with the survivor and or family or friends in person or by phone at their residence or the location of the overdose event. So the Centers for Disease Control and Prevention, who I should express gratitude for funding this work, they funded our grant 3 years ago to really focus on this issue of how to protect overdose survivors, or how these post-overdose outreach programs work to try to protect overdose survivors. And so we had 4 aims in this project, and it's culminating really today with the release of the best practice guidance. And so I'm going to go through kind of the components. So the first question we asked was, how widespread are post-overdose outreach programs? We asked, how are post-overdose outreach programs structured and what are their characteristics? How do they operate? What are their best practices, barriers, facilitators, and unintended consequences? Do these programs save lives? Now that's hard to really decide definitively without a randomized controlled trial or lots of historical data, which we don't have at this point in time, but we did conduct an interrupted time series, which I'm going to summarize for you. And then finally, really the focus today is, what are the best practices and guidance for the programs as we know now? So I'm going to briefly touch on each of these, and then I'm going to turn it over to Tracy to focus on the guidance. So these post-overdose outreach programs are really spreading in Massachusetts. So there were only 23 municipalities out of the 351 that had programs in 2016. This grew to 157 in 2019, and then 245 programs last summer. So the majority of municipalities in Massachusetts have these programs. Now, the fact that these programs were rolled out over time, that gave us the opportunity to look at the association of implementation of post-overdose outreach programs with subsequent opioid overdose deaths among Massachusetts municipalities. And we actually, the submitted this study to JAMA Psychiatry, and they're releasing the paper today. And you're going to see in the chat a link to that paper. Our main finding up here in the upper left is that implementation was associated with a 6% lower annual opioid overdose death rate. We conducted this study. It was an observational natural experiment where we looked at 93 municipalities that had a certain amount of overdose-related calls, and then we looked at how their rates of overdose death changed as these programs were implemented. And what we saw was a gradual and steady improvement in the what's called the slope, or the risk of overdose over time. And this was a statistically significant, small but gradual and persistent association. And so a metaphor, I think, that could be helpful to think about it is if you're driving 65 miles an hour on the road, and then you slow down to 59 miles an hour. You may not feel it in the car, but you're going to get where you're going probably more safely, but also it's going to take you a little bit longer. So that's the type of effect that we've seen. And it was important in this project because every community is different that we adjusted for municipal level factors. And you can see on the slide, there are multiple municipal level factors that we adjusted this analysis for. The features of these programs are that they are public safety and public health teams in Massachusetts in particular, most often police officers and recovery coaches, but many times other people are engaged, other experts and other community resources are engaged to be on the outreach. They occur within days, like 1 to 3 days. Some of them, about half of them, do tele-outreach first. They call before they go to the house. They are persistent, usually 3 or more outreach attempts, and they commonly work with families when they engage. There's community collaboration across programs. They're more and more being funded. Over 3/4 of these programs were funded with external grant funding. Much of it is coming from federal sources. Many of the officers that are involved are in plain clothes, but not all, and they're typically using unmarked vehicles. There is this issue of coercion that came up. So 81% of the programs in Massachusetts, when we did the survey in 2019, reported that they assisted with involuntary commitment, and 57% of them conducted pre-visit warrant checks. So this is an area that we speak to in the guidance. Across all of the projects in Pronto, the role of law enforcement came up. So there's this paradox that we have. On the one hand, in many communities, especially in Massachusetts, law enforcement has taken the lead in developing programs. They have access to the 911 call data. They have access to some federal and state funding. And there, in many communities, is a void in public health infrastructure or a capacity to respond. Many police departments have taken on being first responders with naloxone. So the post-outreach can be the next step. On the other hand, much of law enforcement's work is drug criminalization itself, which systematically stigmatizes drug use in people who use drugs. And this falls especially on Black, Latino, Hispanic, and Native people who've been disproportionately arrested, incarcerated, and killed by law enforcement. Thus, law enforcement involvement can or may limit engagement of people with the greatest overdose risk. And I just want to show you here, this is the focus of this project is Massachusetts, but we want the implications to be helpful in other parts of the country. And here you can just see 4 different post-overdose outreach programs in other states and how their outreach team composition is similar, but also different. Not all of them use recovery coaches or substance use clinicians or paramedics or police officers. There's really a variety here. Okay, I'm going to hand it over to Tracy. Again, thank you so much for joining us today. And I look forward to the questions and the breakouts.
Great, thank you, Alex. I'm Tracy Green. I'm really glad to be here all today with you. I'm going to take us through this last aim, the fourth aim of the PRONTO study, which was to develop and refine best practice guidance for post-overdose outreach programs. And this was especially important because, as you saw, there was a linked to our analysis, a reduction in opioid overdose mortality for the community. So to do that, we went through a very rigorous process, a consensus process, where we invited 13 national policy and program experts to work with us to develop that recommended guidance for post-overdose outreach programs. And while it was informed by the current literature and the research findings that we were undertaking and we're starting to see, we also really expected that the experts on our guideline development group would share and bring a lot of their own experiences to bear. And so that expert process is called a Delphi process. We modified it slightly to accommodate for many things, including COVID-19. But we did this through 4 rounds of review by that panel. So the process involved 2 rounds of asynchronous web-based surveys. Then we followed that with 2 days of synchronous meetings to discuss the areas that were where we didn't have consensus immediately. There were a lot of things that people could agree on immediately. And then we went through a process of asynchronous review of a draft guidance document that we developed, and then several rounds of finalizing the best practice guidance. And the website contains, and there's both a QR code and on several of the pages you've seen and slides that you've seen so far, the QR code takes you to specific information. In this case, the website PRONTO-postoverdose.org contains all of that information and, of course, the guidance itself. So the next slide reflects our sure how to do that one. Thank you. The guideline development group, our experts broadly represented community programs, public safety, people with lived experience, researchers with people with who use drugs, research experience, post-overdose outreach programming itself, and law, public health law, and justice-involved populations. So a wonderful group of people who spent a lot of time with us, and we are very grateful to their participation. The next slide, just as a reminder, a short version of the post-overdose guidance can be found on the right-hand side. It's a 1-pager. And then on the left-hand side, you can go and see the longer guideline development itself. We're developing both the process and the specific section-by-section results. But now I'm going to try and just mention, though, this process, while it involved many people and many processes, we did get to a full consensus. So what we're going to highlight today reflects that full consensus from the guideline development group that we reached on these documents. So highlighting some of those, we're going to start with the orientation, which we could really see that in this case, the overarching theme is that overdose is a public health issue. And because of this, post-overdose outreach should be led and driven by public health principles. From them follows the goals that we identified, and the group identified these primary goals for post-overdose outreach programs. That should be to prevent fatal overdose, to connect survivors with harm reduction resources, evidence-based treatment for substance use disorder, and recovery supports, to engage people at high risk for overdose who are not otherwise receiving services or practicing overdose prevention. And because of this, to optimize engagement with the people they're connecting with, it's really important to minimize criminal legal consequences for the overdose survivor and or others present at that overdose visit, that post-overdose visit. So based on that, next slide, could see a couple things that were really important. And we started with program staffing. So staffing for these programs, we felt, and the group reflected, that there should be familiarity with local resources, that evidence-based care should be prioritized, that lived experience can be a strength, that trauma support is critical and needed, and that overdose survivors should advise the program staffing. So in a local environment, that overdose survivors should have a voice in what the program staffing should look like. But training and supervision is really critical for these programs. And in this case, we could identify and heard from our experts that local resources were important, that the rights of people involved in this visit were really important to learn about, and that the process of informed consent and how to obtain informed consent from survivors is a training point and one that requires supervision. Other topics that were important incorporated overdose prevention, substance use disorders more generally, what the treatment system looks like, harm reduction, trauma-informed care, bias and stigma, and data safety and self-care. Now, law enforcement, in particular, as personnel and program staffing, comprised a good bit of what we talked about. And I think this is important as we spoke, exchanged, revisited these sections really at length with the guideline development group. And the sections that reflect both law enforcement involvement as personnel and staffing, as well as in the visit procedures, are in sections 2.4 and 5.4 for those reading at home. But really acknowledging the paradox that Alex spoke of earlier, and the data that you've heard about, as well as ongoing conversations about policing in our country, we came to a point of consensus that the guideline development group and the research team and the research itself could support. So looking at the role of law enforcement personnel as program staffing, these couple things came through and I'd like to highlight. One is to really consider the community relations when formalizing the role of law enforcement in a community. The second is to minimize actual or perceived coercion by law enforcement staff, prioritizing public health staff contact during outreach, and to train staff in behavioral health de-escalation and crisis response. The next slide focuses on those visit procedures involving law enforcement personnel. And these include things like using unmarked vehicles, soft uniforms or plain clothes to be worn to protect the privacy at the visit, that law enforcement personnel introduce themselves and explain their role to overdose survivors at that visit, to avoid carrying firearms, to establish really clear policies, especially that the team should establish clear policies on how drug possession and paraphernalia will be handled, that acting on warrants should be handled outside of the outreach visit by personnel who are not involved in the outreach team, and that guidance for overdose survivors who are requesting assistance with warrants should be provided, but not proactively provided. And thinking about more broadly, data collection, use, and sharing, something that's common to all of our outreach and the only way we can do this work, that really this information should focus on protecting the privacy of overdose survivors, that treating the overdose survivor information as protected health information should be a focus. Collecting the minimum amount of data needed to do overdose outreach visits, at consenting survivors for data sharing is part of good practice. And to develop explicit data sharing guidelines and make them public for transparency are important to the best practices. Next slide. For visit procedures during post-overdose outreach, services and materials that were really critical and that everyone agreed on were including naloxone, providing naloxone, safer drug use supplies, linkage to treatment, harm reduction, recovery, and social support services. That best practice is to contact that survivor before an in-person visit and to ask for permission to visit. It's important for the team to debrief after those in-person visits, and warrants and involuntary civil commitment should not be used to coerce survivors. Now, the guidance is not exhaustive or comprehensive, and many conversations came up during the course of this work, including in the middle of a pandemic, trying to think of how to adapt some of these things. And then there's certainly topics and areas for other development and research. So these include how to make post-overdose outreach programs work for American Indian, Alaskan Native, Black, Hispanic, and Latino youth, gender minorities, and people involved in sex work. The need to establish public health-centered evidence-based training and technical assistance. How do you minimize stigmatization by medical, addiction treatment, and social service systems? What is sustainable and equitable funding for these programs? What might integration and coordination of post-overdose outreach programming with other efforts look like the 988 call line that came about, and it's an important component of mental health emergencies, or virtual spotting services, as has been offered in Never Use Alone and other programs. I'm wondering in what would interaction during COVID-19 pandemics and the crisis response, what did that look like? And should and how can we adapt post-overdose outreach programming to overdose survivors from other stimulants or non-opioid substances. These are all things that we look forward to talking to researchers and others, both in this breakout rooms and then afterwards to engage in. Next slide. As a reminder to come and visit the program, the PRONTOPostOverdose.org website and see what the best practice guidance looks like in short and long form, please visit us. And wanted to just close with an important reflection before we hear from Mary and Brandon, who are two people with extraordinary experience and lots to share. We can't wait to hear from them. We want to really acknowledge and thank our rock star team, of course, the Guideline Development Group and Mariah. So thank you, and back to you.
Thank you, Tracy, and thank you, Alex, for your presentation. Now we will have our expert discussants, Mary Whaler and Brandon Del Pozo. They're gonna just talk on some points going into a little bit further into some things that you all presented on. And can we have Mary and Brandon come off mute and introduce yourselves, please?
Hey there, can you hear me, Mariah?
Yes, you can.
Great. I guess I'll start then. I'm Brandon Del Pozo. I'm an assistant professor of medicine and public health at Brown University, one of Dr. Green's mentees when I was a postdoc. Thrilled to be here. And I spent 23 years as a police officer. I spent 19 years in the New York City Police Department and 4 years as the chief of police of Burlington, Vermont, where as a small city without a Department of Health, the police department was actually the agency that ran the city's response to the opioid crisis, not in an enforcement-centered way, but as a public health endeavor. So I got to learn a lot about the public health responses to addiction and overdose, and that's what led me into a career with this research. So thanks for having me.
Can you hear me okay? My name is Mary Wheeler. I'm Program Director of Healthy Streets Outreach based in Lynn, Mass. I have been providing harm reduction services in Massachusetts since 1999, including syringe exchange and naloxone distribution since about 2000. We learned about post-overdose in 2015 using Revere Fire Department and harm reduction folks to start kind of figuring out how we could focus on people that we don't see regularly in our daily practice to offer them naloxone and further services.
Thank you both. So I have a few questions here prepared, so I'm gonna just read them to you all, and then I'll have both of you respond to those questions. So the first question we have is, how will this guidance help post-overdose outreach? Either one of you could go first.
Mary, would you like to go first?
So the guidance, I think, helps us think about what post-overdose can look like. If a place chooses to do that type of program, I think it's something that needs to be well thought out and well planned, and really needs to be considered town by town, city by city. And I think that the post-overdose guidance gives people kind of a place to start. And it's not, an end all be all, you have to do it how we say it. I think it just gives folks kind of a good idea of what might be an option and what might not be an option for you.
Yeah, I think to continue with Mary's point, there's a lot of interest, as you can tell by the growth of post-overdose outreach among police departments and communities. There's this excitement for it, but it is a relatively new practice in the history of police work and also in the history of our response to overdose. And we haven't worked out all the details. So this guidance provides us with important details, because I will say, police, despite the excitement, have a lot to learn about showing up at a person who's in need of help's home in other than an enforcement capacity. And then among public health and among people who use drugs, there's issues of perceived safety and trust. I once had a person jump out the back window of an apartment when my officers were knocking on the front door to do post-overdose outreach. Simply just, oh my God, it's the police. They must be looking to arrest someone. So in order to bridge those trust gaps and to make the practice effective, I think we need good guidance. And the guidance here is an important step toward that, right? With a lot of thought put into it.
Thank you for both for sharing your responses to that. And so another question we have are, what are your thoughts about the respective roles of public health and public safety agencies and personnel, especially law enforcement, in post-overdose outreach? Brandon, you want to kick this one off?
I'll make it brief.
Okay.
I think that law enforcement, like was stated earlier, has a lot of information that sometimes other folks don't have access to that can be really helpful to us. I think their involvement in post-overdose outreach needs to be, like I said before, well thought out, and the discussion needs to happen literally town to town, city to city. For our program, there's places where we do have a partnership with law enforcement. There's other places where we don't, except for information sharing. Some places we go out on outreach with the fire department, and we kind of have built those relationships based on our experience working with different departments and our participants' experience and the reputation of departments in their community.
Yeah, I think that police, do have what is one of the very few non-HIPAA protected repositories of overdose patient information, and that empowers them to really be the force behind which doors to knock on in the event of an overdose. But I think it's important, like, not to use that information to like bully their way into the situation or to overstate the role in post-overdose outreach for police. Again, I'm not saying this is an argument from authority, but I did do policing at all ranks from patrol officer to chief for 23 years. And I think there is an important role for police in post-overdose outreach, but they should not overstate their role or overclaim their role, right? This really is a space for clinicians and social workers, medical professionals. And if police want to be there to, number one, show that that they can use this overdose information to a positive end, to offer moral support. And I think also another effect it has is that officer or that unit that does the outreach can go back to their colleagues. And if this person is involved in something down the road that's a minor offense or a drug-related offense, they're there to say, listen, I was at their home, they're trying to get back on track. We need to use discretion and how we look at for the case before, like all of that's important, right? But like police supply the information, they can be a supportive help. Sorry, my camera just randomly zooms out. And but they shouldn't overstate their claim and use the knowledge as like a bargaining chip. They shouldn't use their data as a bargaining chip to have too big a footprint.
Thank you. I know when we were just presenting on the guidance, you mentioned some underrepresented populations. So that's what my next question is going to be geared to. What role do you feel like race and ethnicity play in outreach? Brandon, do you want to kick this one off?
Yeah, I mean, I think that there's an even bigger trust gap with my minoritized populations. Like my colleagues and I have some data that we're preparing to submit for peer review that shows that in a big US city, if you are a Black overdose victim, the person who calls for help, the 911 caller, is much less likely to just say it's an overdose that you're suffering from than if you're a white caller. In fact, the risk of being a Black patient who has a 911 call for an overdose that isn't reported as an overdose, it's reported as, I don't know what's going on, difficulty breathing, it's unconscious, but I don't know why. That risk is double for Black patients in this city. And that, in our view, reflects a fear of having the police come to the door, right? And so overdose response is literally the police coming to the door once again, right? So as Alex showed with that very compelling bar graph in the beginning, for a while, Black communities were underrepresented in the overdose fatality rate, but they've quickly caught up and exceeded, unfortunately, the victimization for overdose than whites. So it's a very acute risk. But when it comes to policing, there isn't just a trust gap, because I'm saying there's one. Like, our data shows when people are literally on the phone with 911 to try to save a life, they will say things to avoid getting the cops to come. So for post-overdose outreach to work with police in it, it has to thread that needle, and that's going to take a lot of trust building.
Mary, what are your thoughts on that, Mary?
I think we've had a, you know, when stuff happened with George Floyd and we stopped our follow-up program altogether for everyone's safety. I will say, when we do post-overdose outreach, we have Spanish speaking and Portuguese speaking capacity, which is generally what we run into the most. And I think being really thoughtful about who we bring to people's doors is important. Again, if we don't have the information, a lot of times when we get information about overdose, the race or ethnicity is not listed or it's incorrect. So sometimes we're not prepared ahead of time when we go.
Thank you both for sharing your thoughts on that. And then the last question, just based off of your own perspectives and your experience, what areas of opportunity are there to improve the level of positive engagement with historically underrepresented communities? And when I say underrepresented communities, I'm talking about Black populations, Latin populations, Native, American Indian, Hispanic, and youth. And so where do you feel like there's opportunities to improve engagement, just based off of your own experiences and things that you've witnessed in this space?
Yeah, I do, if you don't mind, Mary, want to say one thing that weaves the last question and this one together, which is, you know, if we take at face value that that minoritized populations are more fearful of having the police respond to an overdose, then it follows that if that overdose is reversed at the community level, for example, community naloxone, they're less likely to call 911 and have someone respond, right, to do a checkup, to maybe link to more care. So if police involved post-overdose response is one of the principal means by which the community knocks on doors to provide linkages to treatment and harm reduction, I worry that it won't patch the calls that never become a 911. It won't patch the overdoses that never become a 911 call. Those are the ones that are community reversals that fly under the 911 radar. If those are overrepresented among Black and Hispanic communities, Native American communities, we are missing the opportunity to provide that linkage in the first place. So I think that's like just doubling down on the disparity here. And there's no magic bullet for this, right? Sorry, I just zoomed out. There's no magic bullet for this, other than like very slow and deliberate trust building and being mindful of who you send to that door. Some of the guidance that's offered is contentious among police. You know, not being in uniform, avoid carrying firearms. You know, one of the things I went back and forth with the committee was, you know, it's hard to get the police to leave their precinct without a firearm, but you don't have to display it. It can be hidden under plain clothes. I've spent years like carrying one that way. So there's no pun intended now, silver bullet to mend these relationships, but being really mindful of the little things, like your who you send. Are they from the community? Are they a stranger knocking on the door, or are they a beat cop that really knows the area and knows the neighbors and is trusted, right? How are they dressed? And also one other thing I think that's very important is ironing out that you will not use this as an opportunity to enforce warrants, right? I think that there's a lot of soft peddling about that among police, saying, oh, well, maybe we do need to just do a warrant check just to be sure. That's not, if that's why the guy in my case back in the day jumped out the back window, right? Because he thought the police were there to enforce warrants. And that is a big gap toward building trust in the post-overdose outreach context. You're there to save lives, focus on that.
And Mary, do you have any additional thoughts on that? Okay, well.
Sorry, reading the Q&A.
Okay. Well, thank you both for sharing your perspectives. I think it was really important to have those perspectives, especially Mary being a harm reductionist and frontline worker, and Brandon also having experience with public safety. Thank you again for sharing those experiences. We're gonna now transition into the live Q&A. So if you haven't posted your question, please do that now, add it to the Q&A feature, and our team is now going to answer them live. Some questions, if they're not as complicated, we may just answer it in the Q&A feature, but now's the time for your questions. And thank you all for staying on with us. So you wanna start answering some questions, Alex?
Yeah, well, so I'm gonna ask Mary to answer this first question, which is from Ashley Updike. I seriously question the ethical use of law enforcement in post-overdose outreach, regardless if they're uniform. Law enforcement is not trauma-informed organization or causes harm. Often law enforcement organizations fight against harm reduction movements such as fentanyl test strips or needle exchange. Social workers, harm reduction workers have done this work without police. Why were they included? So Mary, you've been doing this for a long time. You've led these programs. You're one of the leaders in the state. So you've been living through this question. Love to get your input on our thoughts on this.
So from our perspective, they're included for a variety of reasons. One, because they have more information than we have. The other reason for us was, in all of the time I've done this work, it's never benefited our participants to be adversarial with our local police department. In fact, it's made their lives harder because they may not cause more harm to a worker, but they may take it out on folks in the street, which we've witnessed. So part of this project is really bringing public health into that space that may not be trauma informed, educating people about harm reduction, educating them about fentanyl test strips. I know Massachusetts, and I'm not sure about the rest of the country, we had a huge push where fentanyl test strips were distributed everywhere. I think it's important as harm reduction workers that we get out there and show that we are part of the community and that we are part of the continuum of care, and that we're not just some kind of like, oh yeah, we'll send them to the needle exchange. You know, we are part of the process and we are important. And I think that police or first responders in general don't necessarily need to be part of the active outreach. I think it varies again from town to town. And, you know, our experience, we've been out with folks where, you know, folks end up migrating back to the first responder where they don't end up coming to the needle exchange. They end up showing up at the public safety station to get whatever needs met they have, whether that's food, sometimes it's been syringes, a tent, a sleeping bag. And so I think we need to educate folks, and that doesn't necessarily mean showing up at the door with them, but being partners and working together inevitably benefits our folks.
Thanks, Mary. Brandon, love to hear you weigh in on this, and then I'm going to ask you a related question.
Yeah, it's a complex question. And I mean, I always wrestle with the idea that maybe the role of the police is to provide the information and step back, right? So that's not off the table. But I do disagree that, I mean, number one, there's 18,000 police departments in the US, which is the bane of policing. And I know a lot of officers who say, no, my job is to save lives. And when someone overdoses and is suffering from addiction, if I can link them to treatment using the data I've collected about their past overdose, I want to do it. So I know that, listen, history shows that police go in all different directions about this, and that the tenor in our communities and therefore our police is shifting much more slowly than we'd like if we've studied the science as directly involved people. But I think I'll sum up by saying there's two things to say. One, great point. Like ideally police would supply data. There's another question in the chat about why this isn't public health data to begin with. Maybe supply the data and step back. But two, like police are not ideologically long-term forever committed to just locking people up for suffering from substance use. A lot are coming around. And if we reject that or say you have no place in this, it's actually going to slow that reform process.
So Brandon, on exactly that point, from Anonymous, any tips for areas around the state where police seemingly refuse to partner with anyone that treatment providers or recovery coaches for post-overdose follow-up, looking to expand partners to include harm reduction resources and providers? So do you have tips on how to get, when you do have law enforcement partners, to be more harm reduction oriented?
I mean, it's so much of the tenor is set by the person who runs the police department, and most police departments are not Boston, for example, or Springfield. They are small police departments. The average size is, I think, something like 15 to 20 officers. So the man or woman who's at the helm, right, who doesn't come from like Police Island or Mars, that person is selected by a mayor or a city manager. Like, they have a clear mandate to at least account to a city council or a city manager or a mayor. And I remember the day one of my role in Burlington, the mayor announced to I heard it when he announced it to everyone. The chief is going to run our response to the overdose crisis, and it's not going to be police oriented. It's going to be public health oriented. So that was a little different. Some people might roll their eyes, but here's what I'm saying. Like, I had to account to that mayor for what I was doing. And if the police aren't doing it from the bottom up and organically, and they're out there in the street putting up walls and obstacles, like, you need the leadership from the top down to start changing it. That won't happen overnight either. Cops in the rank and file, if they're set in their ways, will resist that for a long time. But there is a person who is accountable to the city for running a police department in every agency, and that is the chief of police.
Mary, you've had experience working with law enforcement and getting them over time. Do you have any tips from a harm reduction outreach programs perspective?
I really try and remind myself of the principles of harm reduction when I'm dealing with folks who may not understand harm reduction. And that goes not just for police, but with families and politicians and wide variety of other humans, is that we teach love and we want people to have all of the information. And I think that it's been extremely difficult for myself and for our program staff over these last years, and a lot of other folks that we work with. And it's not easy and it's not necessarily fun, but when you start to see the change and you start to hear from people coming to the syringe exchange that their lives are different, their experience in the streets are different because of the things that you've been able to train first responders to do. It really, you know, it's good. And I know it's maybe hard to understand. And I think where we are in the city that we're in and the few cities and towns that we work with, we've had our ins and outs, and we've had to remove ourselves from some cities and towns. And we've had to, the difference with our program is that we're the funded entity. So we're able to make the rules and we can pull in and pull out as we see fit. I just, you know, I feel like all of the years back, I look back at baby Mary, and I look back at the things I may have said and done to first responders that cause more harm to people in the street by the way I spoke to and regarded. And I still stand my ground, but in a different way that's thoughtful. And, you know, there's a whole other network of overdose follow-up projects that happen here where all programs, well, syringe exchanges en masse, we have our own kind of internal overdose follow-up program where people who haven't called 911 come back. In Lynn, 1 year, there was 424 overdoses, and then our program took in another 200 plus overdose reports where there was no 911 call, where we were able to follow up with those 200 plus folks just in our exchange. So this program is vast, and I think we talk a lot about law enforcement because, again, they have a lot of information that we need, and it's important that they're trained on the knowledge that we have.
Thanks, Mary and Brandon. Zeming, you had a question that you wanted to address. Can you introduce yourself, read it, and answer it?
My name is Zeming. I'm a social epidemiologist with the Department of Community Health Sciences and Epidemiology in the BU School of Public Health. And it's great to be here and see many folks who are, committed to addressing opioid overdose. I try my best to answer some of the questions in the Q&A sessions. I think most of those, to the best of my knowledge, I try. But there are some ones that, in terms of whether our, Alicia asked a question about family and social supports are shared for those who are engaged in the majority of these contexts, and how are teams engaging with family and other supports in a way that prevents future overdose and meeting those needs of those supports. It's very true that drug overdose arise from the specific social context. And so it's really important to address those social contexts. And indeed, many of our overdose outreach programs include referral services to link recent overdose survivors and their family members to health-related social services. Many include legal services, education, career, jobs, housing, and even food security, in addition to harm reduction services and MOUD. So this is important, and we are doing some follow-up research to assess whether programs with these features they are in a better position to maximize the benefits of these outreach programs by reducing future overdose. So this is a very important question you asked, and we're working to provide newer evidence. Thank you very much.
Thanks, Zeming. There are several questions in the chat about consent, and so I want to read one of them and put that to the group. So any guidance on navigating the consent process? I know you mentioned reaching out via phone before physical outreach. I'm interested to learn more, because if individuals experience an overdose and refuse hospital transport, they may not want to be engaged in this way. How do you navigate this? So I'll say that all of these questions about consent accurately picked up on the fact that we raised it, or it was raised by the guideline development group. And it's a reason, one of the reasons why we called this a guidance and not guidelines. We see the development of more specific guidelines like that would address exactly how people should be consented to be kind of the next step. And so we're really glad that people are raising these questions. Mary went off camera, maybe I can ask Scott from Mika, one of the investigators and evaluators. He knows a lot about these programs. What's the spectrum of consent, Scott, that you know about in programs? And maybe we can go back to Mary, and she can talk about how they handle it with their program.
Yeah, I'm happy to, Alex. Hi, everyone. I'm Scott Formica, one of the investigators on the series of Pronto studies. Alex, I think we really see a broad spectrum when it comes to consent. I think in the absence of guidelines, the communities have adopted practices that make the most sense for them and the configuration of their team and how they're handling it. We know that some sites make efforts to contact the overdose survivor by phone prior to attempting a home-based or an in-person visit. Through that process, they're at a minimum obtaining verbal consent to come out and visit the individual. Others have adopted more of a, I would say, harm reduction based direct approach, where they will knock at the door, whoever answers the door, they will engage with them and first thank them for opening the door and saying, can we provide any services? And I think to a program, at least the ones that we're familiar with, if the person says no, not interested, the team will immediately, leave without kind of pushing the issue or being coercive in any way. So we're seeing that some sites do have written release forms for emergency first responder personnel. So, during the overdose event itself, they might ask sites, the individual or their family members to sign a consent to contact them. Some hospital-based referrals use a similar process. It's really all over the board, but as you said, Alex, I think that this is an area that really needs a lot more work on the guideline side. So with that, I'll maybe turn it back over to Mary.
So for one town that we work in, there was a question about information coming and going back. We get information and then we don't go door to door. What we do is we go, if there's any businesses near where the overdose happened, we offer the businesses naloxone. Also, if there was an overdose inside a business, we offer like McDonald's staff, Wendy's staff, Dunkin' Donuts staff, we offer them naloxone training as well. Or we just walk through the neighborhood and just kind of introduce ourselves like, hey, we're public health outreach. And we don't actually go to anybody's door. And then if there's like a big apartment building where we know there's a lot of overdoses and the door is open, we'll leave some naloxone in the lobby. And, as it disappears, we'll go back and restock it. So I think there's some of our partners will ask folks if they arrive on the scene, they'll be like, do you want to visit from us? Or somebody might come visit you. And as far as Massachusetts, you can't refuse transport anymore in Massachusetts. Once you've been administered naloxone, they changed the law that you can in fact be PC'd to the hospital. You can't be PC'd to the police station, but you can be to the hospital. So that's something a little bit different here in Mass, maybe than other places.
Thanks, Mary. There's been several questions about warrants. And so I just want us to, because I brought that up in my background. We did write a paper that delved in more deeply to what happens in these programs with warrants. And so while in Massachusetts in 2019, over half of the programs did check warrants, what they did with that information actually was quite variable. So in in less than 10% of the cases, they routinely arrested people on the warrants. In the remainder of the cases, there were varying degrees of either ignoring the warrants or using discretion, which meant that it depended on what the warrant was about and what the situation was. What there wasn't, though, was a clear policy or a clear guidance around the warrants. And that's what we really tried to start with the guidance, and the guideline development group really talked about this issue. And the feeling was that in order for these programs to really work effectively, where they're trying to actually outreach to people who are harder to engage, they really needed to minimize coercion. And so if a warrant is being used as a way to exert some coercion, that can potentially undermine the program. So that's how the guideline development group sort of came down on that, was really trying to avoid the use of coercion. I'm looking at the time, right? And we should really honor people's time and move into the breakout groups for those people who are willing and able to continue the conversation going.
Yes, we have come to the end of the Q&A. I know there's still a lot of questions that were not answered, so we are definitely going to record those questions and make sure we put them on our website in a format to answer questions that were similar. And if you do still have questions and you're willing to stay for the breakout rooms, maybe you can even ask your questions in the breakout room discussions. I've seen there was a couple of questions about family or social networks, so maybe wanting to join the public health room, or even the harm reduction room. And we'll make sure that we keep track of your questions. Thank you again, everyone, for staying on. And if you have to leave, we thank you for staying for this first hour. Your questions are important, so we'll make sure that we get those taken care of. I'm going to share my screen and just show a quick instructions of how to join the breakout rooms when I open the breakout rooms. So here, it's very simple. You should see the option down at the bottom once I open the breakout rooms. And I'm gonna open them right now. All the rooms should be open. You can see the topics at the top of the breakout rooms, and you can just join based off of what you said you were interested in, based off of maybe your registration, or even if off of what you heard today, something that you found interesting. Please join that breakout room, and you can see here on my screen who is leading which breakout room. There are 2 harm reduction rooms just because there are a lot of people interested in that topic. So please try to like disperse yourself evenly. If you see a lot of people in one harm reduction room, please join the other, and enjoy your discussions. See you soon. I hope you guys have some good things that come out of your discussions.
We will not be coming back together as a group. So
No.
all the breakout rooms will be closed at 1:30.
Yes.
Great. All right, so we should, I'm running mine here.
We just got a question in the chat about whether the breakout rooms would be recorded, and I think that would be worth broadcasting to our
No, we're not.
folks.
Right?
Yeah.
We're not good. Thank you.